Education for Tomorrow Alliance. We are excited to have you guys. If this is your first time joining us for a Distinguished Speaker Series, welcome. If you are coming back after the years a couple of times after the years we've been doing this, you know the drill. I will give you a couple of logistics. We'll do about 30 minutes of presentation and then give you guys a chance to do Q&A. I'm sure we're all familiar with Zoom by now, but you can either use the chat feature or you can use the Q&A to submit questions, or you can use the raise your hand if you're familiar with that. If you hover down at the bottom of your Zoom bar, you'll be able to see all three of those options. We are in a webinar, so we cannot see you, but whenever it's time to ask questions, we will pull you over and bring you live, ask you to unmute so that you have the opportunity to ask your question as opposed to us just reading it. If you are here to get credit for a class and you need a paper or a one-pager, you don't get that from us. You will get that from your school or the headmaster that does require that. So thank you guys again for joining us this evening. And I will pass it over to Dr. Susan Caffrey, who is one of our EfTA board members and the headmaster of the Academy of Science and Technology at College Park.
Thank you, Corinne. I'm Dr. Caffrey, and welcome to all you students and perhaps parents this evening. It is my honor to introduce our speaker tonight, Dr. Jason Griffith. Dr. Griffith completed his residency and fellowship in reproductive endocrinology at the University of Texas Health Science Center at San Antonio. He completed his undergraduate degree at Texas A&M University, and he also earned a master's degree in physical therapy from Baylor University. After serving 6 years in the U.S. Army Medical Specialist Corps, he returned to Texas to complete medical school at the University of Texas Health Science Center at San Antonio. During medical school, he earned the McNutt and Klein Awards for academic achievement and was inducted to the prestigious Alpha Omega Alpha Medical Honor Society. He has published in peer-reviewed journals, as well as presented original research at national meetings. He is a fellow in the American College of Obstetrics and Gynecology and is board certified in obstetrics and gynecology, as well as reproductive endocrinology and fertility. And now, Dr. Griffith.
Thank you so much for that glowing introduction. I'm really not that interesting in person, I promise you that. I appreciate everybody's attendance tonight in this seminar, and I hope that I'll at least excite you about the field of medicine and specifically reproductive endocrinology. And I'd like to start with what it's about and how you get there. If I could go to the next slide, please. So it is a subspecialty of OB-GYN, which is physicians that monitor pregnancies, deliver babies, and take care of women's health. And the pathway is after medical school, you do a residency in obstetrics and gynecology, and then do a fellowship of 3 years in length in reproductive endocrinology and infertility. And the subspecialty really does cover a broad scope across the field. If I could have the next slide, please. So some of the examples that we encounter are complex surgical problems. Folks with pelvic scarring from either traumatic injuries, infectious injuries, we're involved in the reconstruction surgically. Things in embryology and development that go awry that affect the human reproductive system, we're involved with the corrective surgery there as well. There's a common female problem of endometriosis, where the uterine lining goes back through the fallopian tubes and attaches inside the pelvis, causing scarring, pain, and disability. We're involved in both the surgical and medical management of endometriosis. And we take care of benign tumors of the ovary, fallopian tube, and uterus. And I've got some examples here. If I could have the next slide, please. So this is an example of normal female reproductive anatomy. And what I'd like to focus on in this slide is you see the uterus, which is in the center, is got a triangular shaped cavity. And it really is kind of a pear-shaped organ that's upside down. It develops in utero by two tubes actually coming down and meeting at a place called the perineum. And then the wall between those tubes resorbs to give you that kind of triangular cavity. The free ends of those tubes are the fallopian tubes, and then the ovaries are suspended right next to the fallopian tubes for access to the tubes to pick up the eggs. If I could have the next slide, please. So these are examples of what we call Müllerian anomalies. Müllerian ducts are those two tubes that come together to form the female reproductive tract. If you look at the top left, that's called a unicornuate uterus. That's where only one tube formed and went down and touched the perineum to form that. So they essentially have what you could think of as half a uterus. There's a variant of that depicted next door where the other tube just didn't make it all the way down and it's residual. And they call that a residual horn. As we move from left to right in the top row, the next uterine malformation is called the bicornuate uterus. That's where those two tubes actually fuse lower than they should. So there is a unified bottom part of the uterus, but the uterus is separated at the top, creating kind of two horns, and they call that a bicornuate uterus. As we move to the left again, there's a uterus didelphys. This is where those two tubes didn't touch at all in the midline, but touch together, and they actually have two cervices in two uterus, and that's called the uterus didelphys. Now, the wall between those two tubes is supposed to resorb to allow you to form that triangular shaped cavity. If you look at the bottom left, that's called an arcuate uterus, which is where that wall partially resorbed, but not quite all the way. And then as we go to the right on the bottom row, you have the septate uterus. That's where the wall doesn't resorb at all, as you see with a complete septum, or resorbs part of the way. And the subspecialty of reproductive endocrinology takes care of either reconstruction as it comes to a septate uterus, potentially a bicornuate uterus in rare circumstances, or a unicornuate uterus that has residual horns, and also managing some of the reproductive challenges that some of these women have with uterine malformations. Okay. Operative photo of endometriosis. On the study you look at can affect as many as 5% of the general population, depending on how it's scored, and up to 50% of the patients I see in the reproductive world, reproductive endocrine world. As you're looking laparoscopically, so that's a camera that's through the belly button, looking down in the pelvis. If you look at the top left, you see that little darker spot there. That's a collection of the lining of the uterus that's actually stuck to the wall of the abdomen and actually embedded. Now, the problem with those areas are they cause inflammation. And if they're on areas of nerve endings, that can cause pain. And it can vary with the menstrual cycle because these spots are still hormonally responsive, just like the lining of the uterus. So this can cause a great deal of pain, disability, and infertility. And as a reproductive endocrinologist, we frequently are operating on these folks to reduce the disease burden as it affects both their functionality, activity of daily living, just quality of life, as well as their reproductive function. If I could have the next slide, please. Another benign tumor that we address that's very common, especially as women get older, something called fibroids. They're also called myomas. Now, these are benign muscular tumors of the uterus. And with the passage of time, sometimes cells just start to replicate that normally aren't supposed to replicate. And they can collect into a bundle of muscle that can distort the uterine architecture and cause pain, infertility, abnormal bleeding. And we're frequently charged with removing these fibroids to restore reproductive function as well as quality of life. So as you look at this picture to the left-hand side of your screen, that's where we've opened up the uterine musculature that you see there. And that ball of tissue is that fibroid. And we're gently dissecting that fibroid out so we don't disrupt that uterine cavity that would hold a pregnancy. And then as you look to the right-hand side, you can see how we've repaired the muscular wall. That is incredibly important for folks that are wanting to get pregnant. We want to have that uterine wall integrity so it can hold a pregnancy, until term. If I could have the next slide, please. Now, a dermoid cyst is one of the many benign tumors of the ovary. And if you ever want to see some very interesting and strange pictures, just Google dermoid cyst. This is where an egg inside the ovary undergoes something called parthenogenesis, kind of like a self-fertilization. So it starts to try to develop a little person. The problem is it only has half the DNA, so the expression of those genes is very chaotic. So these tumors frequently have hair, teeth, sebum secretions, and they can get quite large, cause pain, twist the ovary, and interfere with reproductive function. The reason reproductive endocrinologists get involved with this is because we are very interested in sparing the ovarian tissue for future function, not only for reproduction, but also for hormone production through a woman's life. And so this slide shows us opening the ovarian cortex and gently dissecting that benign tumor out. If I could have the next slide, please. So infertility is the I in REI, and that's what most of us do in private practice for most of the time. And specifically now, IVF, or in vitro fertilization, is where we spend a lot of our time. And in vitro fertilization simply means fertilization of the egg outside of the body in a lab. Can I have the next slide, please? So this is a cartoon that deals with something that we call the hypothalamic pituitary ovarian axis. It's basically the reproductive hormone control path that we utilize every day in reproductive endocrinology. And it starts in a little area of the brain called the hypothalamus. The hypothalamus secretes a hormone called GnRH. Now, we're not very creative in reproductive endocrinology. GnRH stands for a gonadotropin releasing hormone. This hormone goes down to the pituitary gland and releases the hormones that turn on the gonad. These are specifically FSH, follicle stimulating hormone, and LH, luteinizing hormone. And the pulse frequency of the GnRH determines whether it's FSH or LH at different times in the cycle. In the first half of the cycle, where a woman's recruiting an egg to ovulate, FSH is dominant. It then passes through the circulation to the ovary and stimulates an egg within a follicle to start developing. When that follicle gets to a critical size and the egg has reached the right developmental stage, the pulse frequency will shift and then LH surge occurs. That's what actually triggers ovulation. And we're not very creative again. LH means luteinizing hormone, which basically means to turn yellow. So after the egg ovulates, the space around there becomes the corpus luteum, which is the yellow body. And the reason it's yellow is it's producing a lot of steroid hormones, in this case, estrogen and progesterone. And that corpus luteum continues to produce that until a woman is pregnant, and then it continues to produce on through the pregnancy in the first trimester. Or if she's not pregnant, it's on a timer, it sheds. Now, this cycle is what we manipulate in fertility treatment. Could I have the next slide, please? This is a sonogram picture of what an ovary looks like at rest. And what we do in IVF specifically is something called controlled ovarian hyperstimulation. So these are what the ovaries look like before we start. Could I have the next slide, please? This is what the ovary looks like after we're done. So we've given them both FSH and LH in a controlled fashion, hijacking that hypothalamic pituitary axis through a series of injections that usually last about 10 to 12 days, similar to what happens in the body in the first half of the cycle. Can I have the next slide, please? Once those follicles are developed, we then have to retrieve those eggs. And this is a sonographic image of the egg retrieval process. As you can see on the top of the screen, there's that bright white line. That's actually a needle that's being guided ultrasonographically through the vagina and into the ovary to aspirate those eggs. And those eggs are aspirated and collected for fertilization in the lab. Now, before the 1990s, we did not have transvaginal ultrasonography. So all of these procedures were done laparoscopically. So the burden of patients doing IVF was much greater in the past. Can I have the next slide, please? And this is what embryo development looks like. So the egg is fertilized in the lab. And if you look at the top left-hand side of the screen, you see that large circle and those two small circles in there. Those are called pronuclei. Those are actually the egg DNA and the sperm DNA coming together to fuse, and we call that syngamy. And as you go from the left to the right-hand side of the screen on the upper deck, you can see that the embryo rather is starting to divide. And as you get to the bottom picture on the right, that's a day 5 embryo, and that is now called a blastocyst. What makes it a blastocyst is you see that empty space, which is fluid filled. You see that mass at the top of it, which is called the inner cell mass. That's what's actually going to be the baby. And then you see that rim of cells on the outside. That's the trophectoderm. That's what's going to be the placenta. And what's truly amazing is when you look from the top of this slide to the bottom of this slide, that's only 5 days. And you've gone from 1 cell to 300 cells. It is truly remarkable. And interesting fun fact, the largest cell in the human body is the human egg. Can I have the next slide, please? Now, once we have an embryo, we've got to put it back in. And what you're looking at now is a side view of the uterus ultrasonographically. That bright line coming in from the left to the right of the screen is the embryo catheter, where we then place the embryo back into the uterus at a time point in the cycle for implantation. So IVF in a nutshell takes about 10 weeks from start to finish. Hijacking the hypothalamic pituitary axis, then stimulating the ovaries, retrieving the eggs and fertilizing them, growing those embryos in culture, and then preparing in the next cycle the uterus for transfer, and then putting the embryo back in. So from start to finish, it's about 10 weeks. Can I have the next slide, please? Some fun IVF facts. Now, I know most of y'all aren't old enough to remember any of this, but I remember vividly the first successful IVF cycle, 1978, performed in England. It was Edwards and Steptoe. And quite recently, Steptoe and Edwards were awarded the Nobel Prize in medicine for their success in 1978. Now, in 78, they were also working with an American institute called the Jones Institute in Norfolk, Virginia. But the reason that the first successful IVF cycle was in England is Congress would not allow that in the United States. Well, a couple of years passed, proof of concept, was there. And then in 1981, the first successful IVF case was in the United States, and that was at the Jones Institute. Now, as IVF has evolved, we've gotten better and safer at it. Early on, we used to fertilize multiple eggs and put back multiple embryos, just hoping something would stick. And that's why through the 80s and early 90s, there were all these stories of, miracle quintuplets, miracle sextuplets. Well, that was where occasionally it worked too well. Now, over the course of the last 5 years almost, we've gotten much better, and now we can put back just one embryo and have a very high success rate and prevent those risk of multiples. If I could have the next slide, please. So my pathway to get here was just a little bit convoluted. Next slide. Of course, I started at Texas A&M. I got a degree in kinesiology. And then had a military commitment. So I left Texas A&M and went to the service. And the service put me through the Army Baylor physical therapy program. And I earned my master's in physical therapy. Served just shy of 7 years there and decided I need to get out and get a real job. Can I have the next slide, please? So I went to medical school at the University of Texas Health Science Center in San Antonio. Great institution, great layout, great county to learn medicine. Can I have the next slide, please? And I also did my residency and fellowship there. Bottom line, medicine is a great path for anyone who's interested in science, working with their hands and taking care of people. And the one thing I'd like all of y'all to just think about is if you love what you do, you'll never work a day in your life. I really appreciate you listening to this presentation, and I would love to entertain questions.
Great. So we will give students, if you want to go ahead and put your your questions in. Again, you can use the chat, or you can use the Q&A, or you can raise your hand. We will, as we get those started, I would love to ask you a little bit about, you mentioned that you still actively do research. Kind of what is that ratio, or how do you see patients and kind of do the regular day-to-day practice stuff, and then also do the research? How does that, is that pretty typical? Is that some, like, how do you make that work?
Well, it can be a juggling act at times. The research we do now, mainly in private practice, is in collaboration with industry, because the funding source is incredibly important. So we will get projects from time to time from different pharmaceutical companies where we do IVF trials. So you're still actually practicing medicine, but you're doing it in a controlled, fashion where you're actually tracking outcomes. And I think that's critical to the development of medicine. And the reason I say that is, we all have an impression of what's going on that is subject to our own biases. And our biases are, based on experience and based on preconceived notions. And to participate in the research and actually see the outcomes when you've controlled for as many things as you can, we learn more. And I think staying on that, kind of leading edge is critical to the advancement of any field.
Again, I'll remind students they can ask questions. I'll keep asking a couple until they do.
I put them out of sleep.
No, I think it's fascinating, especially the fact that you had a kind of a PT, a physical therapy stop on the way is clearly not typical. What was it that made you make that turn into, medical school, and also specifically this sort of subfield?
Well, I didn't have much medical experience growing up. I was pretty fortunate. I was pretty healthy. And in high school, I had a significant football injury that I had to do rehab. So I had physical therapy for about 5 to 6 months when I was in high school, and really liked that field. It was, there was a medical component to it. There was kind of a sports component to it. There was a science component to it. So the reason I chose to do an undergrad in kinesiology is I wanted to go to physical therapy school. And then when I was a physical therapist, I was exposed to a much broader aspect of medicine and realized that, okay, there's a lot more that I want to do. Not that I wasn't, I guess, content being a physical therapist, because it just wasn't, there was still an itch I needed to scratch. I needed to go deeper. I need to expand my role in healthcare. And then went to medical school thinking I was going to do orthopedics, because that was kind of a natural extension of physical therapy. And then in your third year of medical school, you have to rotate through all of the services. And when I rotated through OB-GYN, which I was admittedly dreading, not knowing anything about it, the first night on call, I delivered a baby, and nothing I had experienced compared to that in the world. And so I rotated through all the other rotations, and OB-GYN is what I liked the best. And then when I was a resident, you rotate through the subspecialties. And as an intern, I rotated on the reproductive endocrine service, and we were doing a lot of complex reconstructive surgeries. IVF was, really getting good, at that time. We were learning a lot about genetics that we didn't have before. So it was kind of the area within OB-GYN that I really gravitated to. And then it just took my wife, I had to convince her to let me do 3 more years, but she's glad we did it.
That's fair. Very good. All right. So I'm going to go ahead and bring Colton over to ask his question.
I just brought you over, Colton. So if you want to unmute and ask your question.
What is your favorite part of the job?
Oh gosh, the favorite part of the job is telling someone that's been trying to get pregnant forever that they're pregnant. That is the biggest kick out of life for me. Do you mean procedurally? Procedurally, what's my favorite part of the job, or just everything?
Just in general.
I think in general, it's the sense of satisfaction that you get when you help folks that have been, doing all the right things, trying so hard, encountering roadblocks, and you're finally able to help get them over that hump. That is an incredibly satisfying experience, and I'm blessed that I get to do that, on a regular basis. The procedural aspect of my job, I love to operate. There's something about being in the OR, seeing something, being able to fix it, and making a difference is great. One of the honest, challenging things, Colton, since IVF has gotten better, is we now operate less. Before, when IVF wasn't as good, we used to do a lot of reconstructive surgeries to try and optimize, natural fertility. As IVF's gotten better, safer, and much more effective, we end up doing a lot more IVF than trying to reconstruct some of those things. But I enjoy IVF.
Thank you. It looks like we maybe had some challenges with the Q&A. So Isadora, I'm going to go ahead and bring you over. Oh, it looks like Corinne's got you. Go ahead and unmute.
Hi. What would you think is the next step in IVF technology in terms of like advancement or things that are going to change in the next, say, decade or so?
That's a great question. And I think it's a question that's going to challenge, society a little bit, to be honest. Now we can do something called pre-implantation genetic testing. And what that means is that little embryo that I showed you, that little day 5 embryo that's got that inner cell mass and that little ring of cells around it called the trophectoderm, is we can biopsy those cells that are going to be the placenta, so it doesn't hurt the baby, and run genetic testing on that. So what are some examples of that? So if a couple both are carriers of a genetic disease, let's say the most common being like sickle cell anemia, cystic fibrosis, if they have a baby naturally, well, there's a 25% chance that both parents are going to give the disease gene to that kiddo, and they're going to manifest the disease, either sickle cell anemia, cystic fibrosis, or thousands of other diseases. Now we can test that embryo and see, does it have one copy of that gene and it's just a carrier, 2 copies of that gene, meaning it would manifest the disease, or no copies of that gene. And so we can in effect take that out of the equation in reproduction. The other thing we can do with that is screen the chromosomes. As you guys are aware, I'm sure, is that all those individual genes, about 50,000 in humans, are organized, into chromosomes. You get a set from your mom and a set from your dad. Well, in reproduction, the eggs got to divide in half and the sperm's got to divide in half so you can come to be a new person. Well, there can be disorders in that division where you end up with a chromosome extra or a chromosome missing. And that's what likely leads to miscarriage and things like that. So we've been utilizing that technology more frequently now to identify the embryos that have the highest chance for success. Now, as we're learning more about genetics, and it really is kind of one of those frontiers like space, we're starting to figure out what causes what traits are associated with what, and there's going to be more genetic selection on embryos, and how far that goes is something that we're going to have to keep an eye on. Right now, everybody is focused on prevention of disease and reduction of things that are burdensome to health, but as we learn more about genetics, there are going to be other things that we can test for, and we're going to have to ask some tough questions. Should we do that? Is that ethical? Is that justified? And that's what I think in the next 10 to 15 years, the field of reproductive endocrinology is going to face is, where is the genetic line, and how do we not cross that?
Fascinating. Very good. Thank you for that. Ira, we're going to bring you over for your question. If you want to unmute yourself.
Yes, my question was, what do you think is the most difficult or like your least favorite part of the job?
that when fertility treatment fails, when, everybody on the team, the couple, the doctor, the nurse, everybody's giving it their all and it just doesn't work. That is the hardest part. And it's a spectrum of difficulty. It could be that they're not pregnant. It could be that unfortunately they got pregnant and then miscarried. It could be that they got pregnant and it's a pregnancy that migrated into the fallopian tube and then now you've got a medical emergency. Anytime there's a failure in treatment where someone has put everything into that with such optimism, such, expectation and such, physical demand, and it doesn't work, that's the hardest part. But fortunately, that's becoming less and less as we become more successful.
Okay, thank you.
Absolutely. Thank you.
Thank you, Calliope. We will bring you on over. And if you would unmute yourself and ask your question, please.
What's the hardest operation you've ever done?
Oh, the hardest operation I've ever done. So there was, when I was a fellow, there was a 13-year-old girl with something called a oblique septum of the uterus. So if you remember that picture I showed you where the wall didn't absorb, she had one where the wall, was at an angle. So part of the problem was when she had menstrual cycles, half of the uterus would have access to drain. The other half would collect that menstrual blood, swell the uterus and cause pain. And she had had multiple operations trying to fix this. So we finally did an operation where we actually did like a C-section incision and it took her uterus kind of outside the body, opened it from front to back, cut that septum completely out, reconstructed her endometrial cavity, the lining of the uterus and the musculature, and put it back in. And fortunately, that was a success, but that was probably the hardest operation I've ever done.
Thanks, Calliope. That's fascinating. I can only imagine. So you're sort of, you tell me if I'm wrong. You seem to be, if the first type of work around this was done in like the 80s, I'm guessing you have seen a lot of advancements in the time you've been kind of cutting edge, and lots of advancements from the time that you started until now. Can you talk a little bit about sort of some of the changes you've seen? What were the kind of the groundbreaking things at different stages throughout your career?
Absolutely. So that's one of the advantages of having some gray hair is you've got to see the timeline, especially in a relatively new field. So when you look at the first IVF cycles, okay, those were what's called natural cycles. So we didn't have the drugs to stimulate the ovaries, and we didn't have the ultrasound to time and know when the eggs were going to be mature. You kind of relied on menstrual cycle history and you relied on hormones. So they would say, okay, this egg's likely to be mature, do a laparoscopy, aspirate that egg. And if it was mature, then try to fertilize it and then put it back in. So the success rate of IVF in the early days was about, of the cycles where you got an egg that was mature, was about 10 to 15%. Now imagine a 10 to 15% chance of success having to undergo a surgery each time you do it, so that's quite remarkable. Then we had the development of the drugs where we could stimulate the ovaries. Okay. Now, part of the problem when we had the drugs to stimulate the ovaries is we didn't have drugs to prevent premature ovulation. So about 15% of the cycles, you would go and try to harvest those eggs and they would have already ovulated. So when we got drugs then that could stop ovulation, we could really master controlled ovarian hyperstimulation. And that was in the early 90s. With transvaginal ultrasound, it really cut down the burden of this. But then we didn't understand much about embryo development. We understood the mechanics of getting the eggs. We understood the mechanics of fertilization. But around 92, we started saying, okay, now we can grow these embryos and start to freeze them. So we were able to freeze embryos. Now we couldn't grow embryos past day 3. So these embryos are now 6, 8 and 10 cells, not very advanced. So we also only had a technique to freeze where you had to slow freeze them. So you took them in a stepwise approach down to, negative 20 degrees, C, and it took about 3 hours to do that. The problem with going slow like that is there's a lot of osmotic stress from the cryoprotectants that you use. So embryo survival at that time, when you thought them, was only about 2 out of 3, and the success rate from a frozen transfer was about half that of a fresh. In the mid 90s, now your success rate is about 35% with IVF. So we get to the mid 2000s, so like 2005. Now we can grow those embryos from day 3 to day 5. And the advantage there is now you don't have 8 cells, you've got between 100 and 300 cells, a much hardier embryo. We also developed a process called vitrification. Now it's kind of like flash freezing. And the description I use so people can understand it, it's kind of like Star Wars, The Empire Strikes Back. They drop Han Solo in there, flash freeze. They perk up. Now we have an embryo survival rate of 99% with freezing. And then in the 2012 to 2013 range, we started realizing that, wow, frozen transfers now have actually a higher degree of success than fresh transfers. And the reason being is hormonally, your body was never meant to ovulate 15 eggs at one time. You create some hormonal chaos in the lining of the uterus. Now that we can harvest those eggs, create embryos, and freeze them with very reliable performance characteristics, now I can let the hormonal hurricane pass and really focus on the lining of the uterus to develop under more physiologic conditions. Also, throughout that time, as we've gotten better with success, we've been able to reduce the number of embryos transferred. So like in, the early, 90s, 4 and 5, 6 embryos, putting them in, hoping something would stick was kind of standard. You get to, the mid 2000s, we're down to 2 embryos. You get to 2017, we're down to 1 embryo, which is great because multiples have never been our goal. They've been a tolerated complication to maximize success rate. And now that we can make it a single embryo transfer and still maintain a high degree of success, the treatment not only got safer to perform, but also the pregnancy got safer. And those are probably the biggest things I've seen in the last 25 years.
And I'm assuming, that's amazing. And especially knowing that in general, people are having kids later, right? And so, it kind of creates new options for parents that want to be, those who want to be parents. It's interesting. So students, feel free to chime in. I will keep asking. What do you recommend to a student that is thinking about a field like this? I guess number one, kind of medicine in general, like what steps to take, what things can they do as a high school student or as a college student? And then what advice do you give on helping them figure out what specialization they might be interested in if they want to go into medicine?
Sure. So I think things to do now, if you're entertaining a career in medicine, is do some volunteer work, because, a lot of what's seen, on TV, whether it's, the dramatized version of medicine in some popular shows, or even some reality shows there, it doesn't quite capture the full effect. So I would volunteer. And there's several different, avenues to volunteer. You can volunteer in a hospital, you can volunteer in a clinic, get an idea of, okay, is this what I really like? Is it the concept or the actual performance? And then there are also, summer programs at different universities that are kind of medical exploration that I would look into, kind of a summer camp that gives you some exposure there and just really kind of says, oh, is this really a path, that I want to go? When you are, thinking about what specialty to go into, what is almost universal is your preconceived notion going into medical school. Very few people end up doing that because you have this thought in your mind of, okay, what is this? And most folks are like me, something they never expected, grabbed them and said, hey, this is where you belong. So as you're going through the process, I would say, don't rule anything out. Be open to everything. Try and get everything out of a rotation, because you never know. Pediatrics may speak to you. Psychiatry, may speak to you. Internal medicine may speak to you. And if you really enter a rotation with, an open heart and open mind, I think you'll get much more out of the experience, whatever field you go into, and may actually find your true calling. And the other, I guess, thing I would say is there's not a right or wrong decision when it comes to specialty. A lot of, high performing, high driven scholastic folks, like everyone on this call, has been kind of, conditioned to, okay, there's a right answer. In this case, there can be an all of the above. There are things in medicine that I'd be probably happy doing a host of things. I'm happiest doing this, but if I ended up being a general surgeon or something like that, I would find a lot of satisfaction. So there's not a right answer to that. Open heart, open mind, and put everything into your rotations, and it'll speak to you.
All right, Calliope, we'll bring you back over for another question. I think you're unmuted, so go ahead.
Are there any programs you could suggest or just places to research?
So I want to say, and I'm a little biased because it's Texas A&M, but I believe Texas A&M has a summer enrichment program. Probably the Texas Medical Center, either at Baylor or the University of Texas Health Science Center, Houston. I think they call it the McGovern School of Medicine now. Probably has some as well. I know Baylor had something in conjunction with Rice a while ago, and those should be easy to find. I think you have to apply kind of, in the fall for the summer. So that's something I would, if you're interested, I would look into now. They're just great enrichment opportunities that really let you dive in and see, okay, is this really a path that I want to go?
Thank you. Can you talk a little bit about your office, the structure, how many doctors, and any sort of, if there are additional skills, perhaps business skills that are important for the type of work that you do, in addition to sort of the medicine side of things. So if students are interested in something like that, giving them a little background knowledge, I think would be great.
Oh, absolutely. So our practice has 21 physicians. So I'm the practice director. So basically I herd cats. I just get a consensus on everything. We've got 15 locations. So we've got satellite offices, and we have 2 IVF labs, one in the medical center and one in the kind of the Galleria Piney Point area. So mainly the satellite offices are for improved access for patients, because we see folks a lot. A lot of times when you're going to a doctor, it's for a specific problem, short-lived, boom. For fertility treatment, it's frequent visits for monitoring and things like that. So we have satellite offices, all over town. And each of us go to 2 satellite offices. Like I'm in the Woodlands and I'm in Willowbrook. And I have a couple of days a week at our IVF lab and surgery center. When it comes to business, one of the things no one ever tells you is medicine is, a business. And having some business knowledge is extremely helpful when you're trying to negotiate contracts, when you're trying to see, okay, how is our revenue doing? Where are our expenses? How can we improve this? So I think at least having some business classes in college is incredibly helpful as a physician. Now, I personally hate that stuff. I hate it, but it's essential that you understand it. Otherwise, things can get away from you and ahead of you. We're fortunate in our practice that, two of our senior partners, I had decided to step away from clinical practice, and they have a certain business savvy that, I did not have to develop any further. So they take care of that. We review everything. I have to understand when we review everything, but I don't have to make the strategic decisions when it comes to contract negotiations and things like that. But understanding some business is pivotal. Even if you work as an employed physician in a hospital, you'll have a contract, you'll have a performance component, everything else. And understanding how all that works is definitely going to give you a leg up.
Dr. Caffrey, if you had a question, go right ahead and unmute. Can you unmute? Let me see if I can help you here.
All right, I think I'm muted now. I think students are probably wondering, because we talk about work-life balance and how do you maintain that? And certainly times in medical school, I'm sure there was no balance, but how do you do that now in your professional life?
So, and that's an important generational change that you brought up. When I was training, there was no thought of work-life balance. There was like, hey, this is a calling, and the reason the name resident is there is because you lived in the hospital. But I think a lot of changes have occurred, and probably for the better, from a mental health standpoint, from a burnout standpoint, from a just overall quality of life. So what they've done now is they've instituted in training work hour restrictions. Before it was, okay, you were on call every fourth, and on call meant you're in the hospital at 6 a.m. You didn't go home till probably 6 o'clock in the evening the next day. And that's if you had everything done. That's not how it happens anymore. Now in your first year, you can work 16 continuous hours, and you have to have at least a 5-hour break in between there. And then in your second, third, and fourth years of residency, you can work for 24 continuous hours, but not longer than that. So much better than it used to be. And they've got a float system now too, where people are taking shifts during the day. There's a team that takes a shift at night. So it is easier to find work-life balance. I also think generationally, the physicians that are coming out now are seeking that. And that's why I think that the number of private practice physicians is going down. Most physicians now are employed either by a hospital, what's called an accountable care organization, which is within a hospital network. They're employed by that. Within like a large, multi-specialty practice, like a Kelsey-Seybold is a great example. And there's enough people there where they can kind of spread those things out. So I think work-life balance has gotten better. One of the challenges as a physician is what attracts, I think, most people to the field is the desire to help people, and using math, science, surgery, all of those things to help people is there. So when you're kind of supposed to be off, but one of your patients needs something, that can be hard to kind of reconcile. Okay, what do? I know I need some self-care, but I got this patient that needs this. And that's what I struggle with, is still to this day finding, that balance. As an older guy that doesn't have many hobbies, it's not that difficult for me. But as folks starting their field, I think it's kind of become ingrained in the training program now. It's become ingrained in the practices people join, and there's good mechanisms to ensure that.
Thank you.
It also seems like, there are a lot of people that when they're having a baby, they know I'd be their doctor. Whereas probably at some point in the past, it was like, you might be eating dinner with your family and your patient is having a baby. And so, So some of those types of things have shifted, I think, as well, that they're structured differently in the business practice to make for a little bit of that. That's great. I don't know if it's Tamila or Tamala, but I will ask you to unmute yourself and go ahead and ask your question. It seems you are unmuted, but we cannot hear you. Maybe check your volume real fast, and if not, we can ask you a question for you. Okay. Well, I'll go ahead and ask. It says, how important would you say is it to take medical classes in high school? Or are there specific classes you would recommend?
I'm sorry, can you say that again?
How important would you say it is to take medical classes in high school?
I think from an exploration standpoint, and you say, hey, I want to see if I like this, I think there's some advantage to taking that, maybe an anatomy, elective or something like that. I don't think it's critical in the sense of, oh, I've got to get a leg up before I go into college and have these classes behind me. Because, remember, I was a kinesiology major, which is a fancy word for physical education, going into college. And so you can catch up at any time. But I think from an enrichment standpoint and an exploration standpoint, I think it's valuable, but I don't think they're necessary from, oh, I've got to be on this track this early, if that made sense.
Very good. Thank you. Are there any cases that you've seen that were either maybe too high risk that you wouldn't take them, or any times you took maybe a gamble on a patient that you're not sure, but you took a gamble with something and it worked?
Oh, so there's a component with pregnancy that's always got a risk element to it. So someone, and I can't remember who described this, but they said, being pregnant is the most physiologically demanding stress test known on earth. All the systems are taxed. So there are, patients that, are on the, really, it's really like, hey, you should not get pregnant edge. And most of those folks, we will encourage to use a gestational carrier, also known as a surrogate. There are some folks that they're not open to that option. So typically what we do is we engage, another OB-GYN subspecialist called a maternal fetal medicine specialist or perinatologist, that they specialize in the high risk, pregnancies for consultation. And so if it is one of those, yeah, it's high risk, but it's not irresponsible, the patient really understands those risks and is ready to proceed, then okay, we will proceed in a well-counseled, patient that way. There are some times where, and this is true in any, specialty of medicine, you're like, man, I was lucky. God was really watching out for us on this one. This could have really gone bad. And, we had a lady who, and this is kind of an area that, today is a little bit controversial, but we had a lady who physiologically should not have gotten, or from a health standpoint, should not have gotten pregnant. She had something called primary pulmonary hypertension, which is where the, blood pressure within her pulmonary system is much high. And it's usually a low pressure system. And so with the physiologic demands of pregnancy, the mortality rate, and I'll say that again, the mortality rate is 50%. And so, she decided to keep the pregnancy and continue, and she was fortunate. And we delivered her at 36 weeks. And that's where this first patch of gray hair came from, right there. So yeah, we got away with that one. But we try to mitigate risk as much as possible. We try to educate patients to the best of our ability, counsel them, And if it's within, hey, this is risky, but I want to take that risk, then allow them to, assert their personal autonomy in the process. But there are some patients we will not get pregnant.
That's fascinating. So one of our favorite questions I'll end with this evening. We always like to ask panelists, what advice would you give your high school self?
What advice would I give my high school self? I guess I would say, this is a great time to explore all of your interests. Okay. I would leave nothing unexplored, because never in a million years as a high school student did I think, oh, I'd be a doctor. Explore everything. And that way you will enter whatever your desired field is with the knowledge of, okay, this is my right path. This is my right path. And the other thing I would say is have a good time. Take it seriously, but have a good time. High school is supposed to be fun.
Thank you for that. And I will say we get a lot of students that come to we get a wide range of students, but we do get a lot of students that are very high achieving, that are taking all the AP classes, that are doing very high level research as high school students. And some of them end up taking the exact path, and some of them take those detours. So I think that's great advice of be open, explore, and then be open to it. Well, we really appreciate your time. We always want to respect your time. And so students, I know that we can't see you, but if you want to give some messages in the chat of gratitude, we are so grateful for you sharing that knowledge. And like I said, I think it's fascinating, sort of number one, that you've seen sort of that cutting edge path throughout your career already. And there's the ethical questions. I think that's a really interesting saying where we go from here is we get better at doing the technical side of it. Then what, right? And what does that mean? And so we are so grateful for your time. If you don't mind hanging out for just a second, we'll go ahead and stop the recording here.